Hello, everyone. I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about obesity, hyperlipidemia, and all forms of lipid disorders.
So I guess before we jump into the specifics, it's good to know what metabolic syndrome is, because I think it's a concept that's brought up time and time again, whether it's in cardiology, general practice, or elsewhere. So you need to know that metabolic syndrome is a complication of various diseases. It's not just one disease, it's a combination of many diseases that typically present together and have an increased risk of cardiogenic complications. So these diseases include visceral obesity, hypertension, insulin resistance, high triglycerides, and low HDL cholesterol. Some specific criteria that I think might be worthwhile knowing. I'll say which ones are important, which ones aren't. So increased waist circumference. I don't think the specific numbers are relevant to know. Blood pressure, you should absolutely know the cutoffs for hypertension. Fasting blood glucose above 5.5 is considered abnormal, while one above 7 is considered diabetic. High levels of triglycerides, usually above 1.7 millimoles per liter, abnormal, don't need to know this. And low HDLs is also abnormal. So remember, HDLs are your good lipoproteins and you want more of them, while LDLs are the bad ones. In most cases, you would know why your patients have obesity. You know what led to this. They know what led to this. So a few things that you should absolutely focus on while treating obesity. Again, not so relevant from an exam perspective, but when you're in practice, important to know. Firstly, this is an ongoing process of change. A one-off appointment is not going to help. It's also very ironic when you tell patients to change and lose weight when you know that you're going to go home to a 24 pack of chicken nuggets. As fun as it is, it's a bit hypocritical, and in most cases, try to put yourself in your patient's shoes. Please don't sound condescending when you say certain things. It's a very sensitive issue for a lot of people. So be nice. Just be nice. It doesn't hurt. It's important to set realistic goals. A lot of people might think, oh, I'm going to lose 30 kgs in 2 months. That is obviously unrealistic. And when that doesn't happen, they are extremely disappointed and throws them into a vicious cycle. Hold the patients accountable. Something that I really liked with my GP that he often did, he said that, look, I will try my absolute best from a medical perspective to help you. And I want to ensure you that I'm here to help you along the way, helping you lose weight. However, nothing I suggest is going to work if you don't put the work in. And he was very frank with that. And I think that's important. You need to hold your patients accountable to their own selves. Always stress heavily on lifestyle changes before you consider medical or surgical interventions. And we will talk about what options we have further. So medical therapy, so not all patients are suitable for this. We usually reserve this for patients with the BMI above 37, and niche tidbit is, or if they have a BMI above 27 or above 30, or if they have a BMI above 27 with obesity-related complications like cardiovascular disease or OSA or so on. The three important medications to know are orlistat, phentermine, and liraglutide. Now we'll talk about each one and what they do. So orlistat is a reversible lipase inhibitor. What it does is it reduces the absorption of lipids in the gastrointestinal tract, and that's obviously going to prevent accumulation of lipids in your bloodstream, and over time will help reduce lipids and reduce your weight. The average weight loss, although, is not very impressive. It's about 2 to 3.5 kgs at 1 year's time. And some important side effects relate to fat malabsorption. So again, if the lipids and fat are not going into your body, they will be going into the stool and will be staying in the stool. So important to know that. So steatorrhea, you also need to know that with the malabsorption of fat, you are going to have issues with absorption of vitamins that are fat soluble, and these include your A, D, E, K vitamins. Pancreatitis, and you need to know that orlistat is contraindicated in pregnancy. Phentermine is a sympathetic agent that suppresses appetite. As you can imagine, when you're super stressed, Hunger is not one of the driving forces. It's not to be used in patients with cardiovascular disease because, as you can imagine, increasing a person's sympathetic drive increases cardiac output, increases a lot of cardiogenic activity, and we don't want to put additional stress on the heart if we don't have to. The average weight loss is a bit better, about 3.5 to 4.5 kgs, and we obviously risk excessive sympathetic overactivation. Lastly, we have liraglutide, and liraglutide is a GLP-1 agonist. You might have heard this before. This is commonly used in diabetes, and it was first meant to be a diabetic medication. It works by suppressing appetite and is safe to use in cardiovascular disease and has the best weight loss of the three. Now, bariatric surgery, which is your main surgical therapy. It's reserved for patients with a BMI above 40 or, again, 35 with obesity-related complications. The three ones are gastric banding, gastric bypass, and gastric sleeve. I also don't know how to pronounce this, so I will not try. But I did try and failed miserably. I don't think you need to know the specifics of what these are or what circumstances warrant one over the other, but I've included it for completeness sake. Anyway, gastric banding, what it basically is you have an adjustable band across the stomach, and you have a port that's placed under the skin. When you inject saline, it constricts, and as you can imagine, you have early satiety with this. With the gastric bypass, it's the most efficient way, so you completely circumvent most of the stomach and the first part of the duodenum. And then with the gastric sleeve, it's the easiest to perform, and you just remove a part of the stomach. What you need to know is that the risk of complications, especially earlier complications, is highest in gastric bypass, and you also run the risk of malabsorption. That's something to consider. Next, let's talk about dyslipidemia. So when we say dyslipidemia, we don't just mean high cholesterol. We have a few different lipids we look at, and abnormalities with any of them would constitute dyslipidemia. So we have total cholesterol, triglycerides, LDLs, and HDLs. So I guess the question is, when you do a blood test, right, you can have all abnormalities with all of them, but very commonly you have one that's a bit more elevated or issue with one over the other. So if you have an issue with the LDLs, statins and ezetimibe are highly efficacious versus something like a fibrate that's really effective for triglycerides but doesn't do much for LDLs. You also need to know that the treatment goals, or what we hope to have, are quite different. So with total cholesterol, so we want to keep the triglycerides to ideally less than 2, total cholesterol less than 4, LDLs less than 2, and HDL more than 1. If your triglycerides are less than 4, so between 2 and 4, we can just go with the statin to begin with. If it's 4 to 10, statin and fibrate. Apologies. It should be the other way around. So 4 to 10, statin plus fish oil, and then above 10, statin and a fibrate. Fibrates are really, really good at reducing triglycerides in particular, and we'll talk about them in a second. So statins work by acting on the HMG-CoA reductase enzyme. They lower LDLs in particular, and some important complications you should know are myalgia, and in some cases, rhabdomyolysis. And as you know, rhabdomyolysis would present with myalgia, but also would have an elevated CK, and typically they can say that their P has turned red, and that's because of myoglobin that's been greenly excreted. An example of a commonly used statin is atorvastatin. You then have fibrates. Fibrates lower triglycerides. The important thing you need to know is that with super, super high levels of triglycerides, we run the risk of pancreatitis. So whenever the triglycerides are above 10, and remember, this is very high, your normal triglycerides should be less than 2, you run the risk of pancreatitis. So we stress on fibrates, particularly fenofibrate is a commonly used one. We have ezetimibe, which decreases cholesterol absorption, and it also lowers LDLs and can commonly be used alongside a statin, but is not commonly used for triglyceride abnormalities. And lastly, we have a new class of medications called PCSK9 inhibitors, which are your monoclonal antibodies given subcutaneously, and they they block the breakdown of LDL receptors at the kidneys. So you have more LDL receptors, which means you will uptake more LDLs into the kidney, into the liver. Sorry, let me rephrase. It blocks the breakdown of LDL receptors in the liver. And now that you have more LDL receptors, you're going to be absorbing more LDLs in your liver. And that is good because it takes away more from the blood and actually can be metabolized in the liver. So it's not just going and causing fatty liver disease there. And the PCSK9 inhibitor that is commonly used is evolocumab. As you can see, the mab at the end indicates it's a monoclonal antibody. And that's all we had for obesity and dyslipidemia. Thank you all for coming. As always, any questions, shoot me a message. And please look after yourself and please look after your loved ones.